Welcome to the Explainer. Today, we're taking the incredibly dense 2026 ACC Scientific Statement and the 2026 ACG Guidelines, and we are boiling them down into a rapid-fire, highly practical clinical guide for prescribing direct oral anticoagulants, or DOACs. We're going to break down all this evidence-based data into clear, actionable steps you can confidently use for primary and secondary prevention of thrombotic events. But right off the bat, I want to ask you a serious question. Are you truly optimizing your DOAC prescriptions across the complex, real-world patient populations you see every single day? Despite overwhelming evidence supporting their efficacy and safety over traditional vitamin K antagonists, DOACs are still underutilized. And honestly, they're sometimes inappropriately dosed, especially when we're dealing with patients at elevated thrombotic risk or those with tricky, layered comorbidities. So here is our clinical roadmap for today. We're covering 1. The state of DOACs. 2. Primary and secondary prevention algorithms. 3. Navigating special populations. 4. Bleeding and peri-procedural management. And finally, 5. Your final clinical takeaways.
Okay, let's dive right into Section 1, the state of DOACs, mechanism and efficacy.
To really appreciate why DOACs have completely transformed how we prevent and treat thromboembolic disease, we have to compare them to vitamin K antagonists, like warfarin. This beautifully illustrates exactly how factor XA inhibitors, things like apixaban and rivaroxaban, and direct thrombin inhibitors, like dabigatran, intervene with absolute pinpoint precision to halt thrombosis in the coagulation cascade. Instead of casting a wide net and messing with multiple factors like warfarin does, DOACs give us predictable pharmacokinetics, way fewer drug interactions, and just a dramatically improved overall safety profile. It's a total game changer. Moving down our pathway to Section 2, primary and secondary prevention, clinical algorithms. Now, figuring out the exact duration of anticoagulation is always a delicate balancing act between thrombotic and bleeding risks. Notice how the standard therapy diverges here. Moving up to higher thrombotic risks means longer, much more intensive therapy. But if you move down toward higher bleeding risks, well, that necessitates a significantly shorter duration. This gives us a visual logic for exactly how long a patient should actually remain on an oral anticoagulant, based strictly on their specific clinical indication. To save you from getting completely bogged down in complex flowcharts, let me just give you 3 high-yield clinical pearls for your daily practice when it comes to therapy duration. First up, for a standard provoked VTE with major transient risk factors, you're looking at a standard therapy duration of about 3 to 6 months. Second, if your patient has an unprovoked VTE or a cancer-associated thrombus, you need to be looking at long-term, indefinite oral anticoagulation. And third, for atrial fibrillation with an elevated stroke risk, indefinite therapy is the absolute standard there to prevent devastating cardioembolic events. All right, Section 3, navigating special populations, dosing with comorbidities. So, what happens when hepatic dysfunction complicates your case? Well, OACUs is strictly dictated by Child-Pugh class stages. It's pretty straightforward. Child-Pugh A, that's generally safe across the board for all DOACs. But Child-Pugh B requires extreme caution. You can use apixaban, dabigatran, and edoxaban as long as you're monitoring carefully, but rivaroxaban must be strictly avoided, period. And for severe liver disease classified as Child-Pugh C, there is simply insufficient data right now, which means you really should avoid DOAC use entirely. The absolutely crucial point here is contrasting 2 other highly unique populations. On one hand, you have individuals with class 3 obesity, meaning a BMI of 40 or greater. The evidence-based data is clear. You can confidently use rivaroxaban or apixaban as highly appropriate options. But contrast that with end-stage renal disease patients who are on dialysis. For these folks, dabigatran must be avoided completely because up to 80% of it is cleared by the kidneys. Instead, label-concordant apixaban is your go-to choice. It's been associated with a notably lower risk of bleeding and even a distinct mortality benefit when compared to warfarin. When you're treating frail patients or those with a notoriously high bleeding history, apixaban is consistently the preferred choice because of its exceptionally favorable bleeding profile. Now, interestingly, if you have an elderly or frail patient where standard dosing just isn't recommended, the 2026 guidelines suggest you can consider low-dose edoxaban at exactly 15 milligrams daily. And for a patient with a direct history of prior bleeding, you'll want to lean towards apixaban or a lower dose of dabigatran, strictly at 110 milligrams twice daily. Moving right along to Section 4, bleeding and peri-procedural management. The guidelines heavily highlight the use of bleeding risk scores like HAS-BLED or the DOACs score. But listen, here is a vital clinical takeaway. While you should absolutely use these scores to flag patients who need more frequent follow-up, you must never use them in isolation as an excuse to deny a patient necessary anticoagulation. Don't do it. Instead, use those scores proactively. Hunt down and mitigate modifiable risk factors like uncontrolled hypertension or, concurrent NSAID use. Now, even with the absolute best management, major bleeding happens, right? For your clinical practice, this means you need to know your reversal strategies cold. For dabigatran, idarucizumab remains the preferred agent. However, for factor XN inhibitors, we've seen a massive shift in protocol. Since andexanet alpha was completely withdrawn from the U.S. market back in late 2025 due to thrombotic events, you must now pivot to 4-factor prothrombin complex concentrate, or 4-FPCC, as your frontline reversal agent. And that brings us to Section 5, Final Clinical Takeaways. Look, prescribing the DOAC is only half the battle. You have to routinely act as a clinical detective during follow-ups. You need to actively reassess renal and hepatic function because, as we've seen, that strictly dictates your dosing. Watch carefully for drug-drug interactions, especially with things like anti-seizure meds or proton pump inhibitors. And crucially, always have an honest, direct conversation to assess affordability and adherence, because a perfectly prescribed DOAC only works if the patient sitting across from you can actually afford to take it. We'll leave you with this final thought on patient-centered care, signed off by our clinical guide expert, Dr. Sara Altayeb Omer Altayeb. The data is incredibly strong, and the algorithms are super clear, but ultimately, guideline-directed therapy must be individualized. So my challenge to you is this. Are you treating just the algorithm, or are you utilizing these guidelines to actively balance the unique thrombotic and bleeding risks for the living, breathing patient sitting right in front of you?